This conference will now be recorded.
So welcome to the class. So today I'll be taking class on the endometrial cancer. Updated guidelines are there, FIGO 223, 2023, and also like BGCS also have changed the guidelines. So there had been a quite updates in the this topic. Because of that, I tried to take this class. So uh, if any one of you find any difficulty anytime, then you guys can stop me. Okay, so like first I'll be speaking about the general overview of endometrial cancer, then about the um, staging, then management. Okay, so endometrial cancer is the fourth most common malignancy in UK with the highest incidence of all gynecological malignancies. Okay, so we know there are two types of cancer. One is endometrioid, another one is non-endometrioid. So most of them are endometrioid, that is 80%. This percentage is important for part 2 people. Other cancers are serous, clear cells, carcinosarcomas, and undifferentiated tumors. These are responsible for remaining 20. And the good thing about the endometrial cancer is because the most of them present with the bleeding, so they come to the hospital, to the clinician at very early stage, so that they have a very good prognosis. So 75% we are able to diagnose in early stages, stage 1 and 2. Apart from this, like uterine sarcomas are there. They are rare. They are 2% of the gynecology malignancy, and it is different from the like endometrial cancer, because we are able to diagnose this when we see the histopathology. So this is number one thing. Apart from this, as it do have a blood spread, so prognosis is very poor. Sarcoma prognosis is very poor. Okay, apart from this, now this from there here you find a lot more number of questions. What are the risk factor for endometrial cancer, and what are the protective factors? And so this part is like easy and important to understand. So the usually the age is 65 to 74, and early menarche and late menopause. That means there is too much increased period of estrogen exposure. So this is one of the reason for endometrial cancer. Women who had menopause at 45, and those who have menopause by 50, in between 50 to 54, they have 22% more chances of endometrial cancer. So in that situation, early menopause is good. Okay, that would be protective. Now parity. Each pregnancy reduces the chance of endometrial cancer by 27% of the by the first child. And the women who have two children, they have 38 lower chance of the endometrial cancer as compared to the women who never had any children. Apart from this, this is very important thing, that age at last childbirth is more protective. Like if a patient has a childbirth after 30, they have lower risk of endometrial cancer. That is a sort of a new thing. uh, like why, the reason being given that if they are having children after 30, so when the whole endometrial shedding is done at the time of delivery, so because of that the chances they have decreased chance of endometrial cancer if they have child at like uh, after 30 years of age. Obesity is one of the most important factor that is um, related with the endometrial cancer. We all already know it. It causes obesity causes aromatization of androgen, leading to formation of estrogen and insulin resistance. All are linked, increase the chances of endometrial cancer. Now, HRT, if only estrogen HRT is given, 2.3% times more chances of endometrial cancer. Also, it is there with the tibolone. Okay, so both of them, HRT also and tibolone also. Now, polycystic ovarian syndrome has got 2.8% times high chances of having endometrial cancer, that we already know. And apart from this association with the type 2 diabetes, 40 to 80% risk of endometrial cancer. Why? Because it is linked with the obesity, it is linked with the insulin resistance, and diabetes also appears to be independent factor that is associated with endometrial cancer. Tamoxifen use. We already know that we are using tamoxifen for the treatment for breast cancer. It has got like effect on the endometrium. It increases 2 to 3 fold chances of endometrial cancer. Apart from this, if the tamoxifen like 2 in 10,000 per two cases will be extra in 10,000 of the population per year if the extra use of tamoxifen is done. This number is not too much important, but yes, tamoxifen is important for the like associated with 2 to 3 fold increase in the endometrial cancer. Okay. Apart from this, family history, we already know that link syndrome is there, that has got endometrial cancer risk of 40 to 60%. And like the- now the recommendation is, we'll be reading it in the upcoming slides, that all women who have got endometrial cancer, they should go for like link testing. Apart from this, familial history of endometrial cancer, like though the link syndrome is not there, but if someone has got endometrial cancer in their family, then 7 times more increased chances of endometrial cancer. If they have, if it is like cancer in the family occurred less than 50 years of age, and like first or second degree relative is affected. Okay, so it do have a like association with the link syndrome, that family history. Aside from the link syndrome, only with the family history of endometrial cancer, there is sevenfold increased risk of cancer. Okay, so this part has to be noticed. Apart from this, pelvic irradiation, if the pelvic irradiation is done for any kind of cancer, then there would be increased chances of cancer. And the answer, what really happened after irradiation, it will be adenocarcinoma and sarcoma. This question I have seen somewhere in some of the either it came in exam or some of the books, that with the pelvic irradiation, what type of cancer increases. So it would be like adenocarcinoma and sarcoma. Okay. Now granulosa cell tumor. So granulosa cell tumor is a, we already know that it produces estrogen, so there is a 10 times more increased chances of endometrial cancer. And we have you must be remembering in the endometrial hyperplasia guideline, 40% cases granulosa cell tumor is associated with when the patient has endometrial hyperplasia. Okay. Liver cirrhosis, estrogen degradation is decreased. So here there is a problem with the metabolism of estrogen. That means the increase that causes increase in the estrogen, and that increase in estrogen causes endometrial cancer. It will be very important to know for the part 2 people, because sometimes they will give you a question about the what are the risk factors and which is not. So people will not mark this. So this is important to know. Rather, all other risk factor you already know. Okay, but it is not the risk factor. There are certain protective factors also for the endometrial cancer. So what are the protecting factors? Cigarette smoking. And you will find question from here. Cigarette smoking decreases 20 to 40% because estrogen, nicotine has got anti-estrogenic effect. So this you should remember for the like SBA purpose. Now COC causes protection, that we already know. So 25% of the endometrial cancer can be prevented with the use of OCP. And it is not only COC. COC and POP both are beneficial. And apart from this, coffee intake, coffee in people taking having high coffee intake has got like there is a risk reduction about the like endometrial cancer. So this can also come with your SBAs. Exercise decreases fat, decreases estrogen, decreases endometrial cancer, that we already know. Aspirin also has a protective effect. It has even the aspirin is used as a protection in the women who are having, link syndrome. So aspirin is given to those women. You might have read in your talk. Marina, we already know it causes endometrial atrophy almost, and 78% lower chances of having decreasing the endometrial cancer. And progesterone, even every 10 days of progesterone is given during 28 days of cycle that we usually give when we treat the patient for heavy periods. That also has a protective factor. So it is a good thing to know that so many protective factors are also there, and these are important to know because this usually comes as an SBA. Now this is from the BGCS guideline. So the if there is a 5 uh, kg BM per meter square, if the 5 increase in BMI, 60% more chance of endometrial cancer. If the patient has a BMI of 40 or more than it, they have got a lifetime risk of 10 to 15% of the cancer. LNGIUS decreases of 78% that I have already spoken. This okay, now you have to just give me answer to this. So you are designing a retrospective review of endometrial cancer cases and their associated factors. Now these are the list of factors. So which of these you find that they have increased risk of endometrial cancer? What should be the answer?
B, ma'am, increased age, obesity, estrogen only HRT, and Lynch syndrome.
Yes. Very good. So because of that, we to answer this kind of questions, you have to have an basic idea about the factors that are risk factor for endometrial cancer and protectants also. Many of them, if they don't know that the smoking is a protective factor, they will put their answer this. Okay, so it is important to know that. Yeah, good answer. Now clinical presentation, we already know that prognosis with the endometrium cancer is very good. Why? Because the presenting symptom is a bleeding, and the patient, once any patient who sees there is a bleeding, they'll just come to the hospital. So abnormal uterine bleeding is the present in 90% of the cases. If the Usually in the postmenopausal, okay, and younger women, if the patient is presenting with the irregular bleeding or intermenstrual bleeding, uh, uh, apart from this, they have some risk factors such as obesity, PCOS, family history, and they're not responding to the medical management. We have to rule out the endometrial cancer also. And if a patient though is presenting in an advanced stage, then it is already spread, then they can come with a complaint of pain, changes in the bowel or urinary habit, or lethargy, whatever the red flag signs that the cancer has. If all these symptoms are there, that means it is already advanced. Okay. Now like few part of the class is there from strategy, and I try to cover this guideline, BGCS, and also FIGO. Okay, so it is, I try to put the knowledge that is possible updated from all possible sources. Now what is the and BGCS gives a recommendation only. So this is this what I was saying. So according to their recommendation, all patients having endometrial cancer should be offered link syndrome testing. Okay, testing should be done. Now, too much details of this is histochemistry testing. Too much details about that is not required. This table is also from this guideline only. Just a small overview is important. So usually there is a they do immunohisto chemistry, that is a IHC, and there is they test for four like they test for four things. These are MLH1, 2, 6, and PMS2. Now they have subdivided these in two parts. If the test come positive, IHC test comes positive with MLH1 and PMS2, If these two are positive, then they will do another test, that is a hypermethylation testing. If hypermethylation test is negative, that means there could be possibility of link syndrome. Then they will do germline testing for DNA. More than that information is not required. Only this is the basic thing. I don't know whether the question ever came from it or not, but it is important to know. And another, if the MH2 and 6 and PMS2, here it is MH1 and PMS2, here it is rest of MS2, MS6 and PMS2. If it comes positive, then they would directly go for germline testing, for the link syndrome. Okay, so these two things are given in the, you know, your this guideline. That is important to know. uh, is it clear?
Yes, ma'am. Yes, ma'am.
Yeah, too much details are not required basically. Now apart from this, for the link syndrome, uh, this is important to know. This comes in part 2 and part 3 also. It has already appeared. uh, like what they say, what this guideline, what the BGCS recommendations are there. They recommend a risk reduction surgery. Okay, risk reduction surgery by 35 years in MLH1 and 2, MSH2, 40 years in MHS6, and after 50 in PMS2. Okay, so this appears to be complicated, but yeah, it is written same way in the guideline. So because of that, I have put in the same way. But usually, the risk reduction surgery is done after 35 to 40 years of age. Okay, so risk reduction surgeon will be hysterectomy here, but concurrent BSO can also be done. If the BSO is done along with hysterectomy, then it will decrease ovarian cancer risk also. And this I was saying already. Aspirin reduces the cancer risk, so it is used as in chemo prevention. But yeah, dose is uncertain. If you guys have read the, link syndrome talk. So if the, like more than 80 years 18 years of age, they are considering giving aspirin. Okay, LNGIUS, other progesterones, they would have a, like uh, reduce the risk in link syndrome also. How? By endometrial decidualization, atrophy and apoptosis. Okay, so this part is important for both 2 and 3, because the link syndrome this time, recently it is appearing in both exams. Now, for the general population, here it is like just an query. For the general population, that means if a person has got like no history of link syndrome, then no screening, nothing is required in general population. That is important to know, because this knowledge is important for your part 2 and 3 exam, because sometimes you will find a question saying, the patient wants screening to be done, and then you have to say that if there is no risk, no screening. Apart from this, this guideline says that like screening can be done annually by TVS, by hysteroscopy, and by endometrial sampling after 35 years, till uh, the, like risk reduction surgery is not been done. But again, these kind of thing to be done after explaining the risk and benefit. Apart from this, evidence for this kind of testing, like screening, is not there. Though on the individual basis, after counseling the patient with the risk and benefit, it is done in some units. So these are the screening is done from 35. These are the method, but evidence is not there. Okay, so that part, when it comes in your question, you have to say this to the role player. So these are the methods, but we don't have any evidence for it. Okay, and general population, it is not. Then this much knowledge about the link syndrome is important, because it started appearing in the exam. Okay, the another question. So which of following is not a mismatch pair gene? Easy.
C10 gene, C.
Yes, P10 is not there. So these four are there. Okay. Okay. So according to this guideline about the tamoxifen, what the guideline says about tamoxifen. So tamoxifen, we already know that is a SUM, that is a selective estrogen receptor modulator. It do have an inhibitory effect on on a breast, so we are using it for breast cancer treatment. But it do have a stimulatory effect on endometrium, so it increases chances of cancer in the postmenopausal long term user. So, and the another thing that it is important, that tamoxifen, when it causes endometrial hypertrophy, but it comes at a subepithelial level. Okay, so when you do the ultrasound USG, usually when we do ultrasound, then we measure the endometrial thickness. Okay, so from one end to another end. But in tamoxifen, because it causes subepithelial stromal hypertrophy, this is again a question. Okay, so because of that, when we do the TVS, then you will find ET very thin, though the patient has got symptoms, patient is taking this tamoxifen, but looking at USG picture, endometrial lining will be thin, or ET will be thin. Okay, so you can't use USG too much for the tamoxifen patient. Apart from this, if any patient, current user and ex users of tamoxifen, to be if any abnormal bleeding occurs there, then urgent investigation for suspected cancer is there. This kind of question already there in the part 3, when the patient has taken tamoxifen long back, now she has presented with the cancer. So even it is not that the time during when the patient is taking tamoxifen they will present with the symptom, they can present later on also. Okay, these are things that are given in the guideline about tamoxifen. Now, if the patient comes to you with the bleeding, so what are the investigation? First line would be the TVS. Second line will be histopathology. Now, histopathology first, it varies. Uh, either it could be endometrial biopsy by people, or it could be output hysteroscopy, outpatient hysteroscopy. So it depends. Ideally, best will be hysteroscopy, but everywhere it is not, and it is just an individualized again. So these are the diagnostic method. Now TVS. So whenever the patient is coming to you with the irregular bleeding, the first line investigation will be TVS only. So now this is those who do the ultrasound, they would be knowing it better, but this is the TVS picture, and you can see the endometrial lining. So this is this is the picture of the USG picture of the patient, of the young patient, okay, having regular periods. So this is the triple line endometrium that you can see. This is one line, this is second line, and this is third line. So we call triple line endometrium. So this is the triple line endometrium. So this is a normal endometrium thickness when we see it on the ultrasound. But in postmenopause, we already know that AT becomes very thin, less than 4 mm. Ideally, it should be there. Now you can see this is the postmenopausal uterus, a little small also, and you can easily see the ET. This much is the ET. Okay, this much is the ET. So this is sort of a normal thing. So endometrial thickness, if it is less than 4, then it has 99% predictive value of endometrial cancer. So I think this number is also asked sometime in the exam. Apart from this, if the woman is taking HRT, then endometrial biopsy to be performed when the ET is more than 5 mm. Okay, more than 5 mm. So this is written in this guideline. Previously, when question used to come, then there was always a query from where to answer. But BGCS gives this number. Another important thing, that this is what this guidelines say. If now the patient, you can get a question that the patient is presenting with a postmenopausal bleeding, and ET is less than 4, and she has come with episodes of bleeding 2 3 4 times. So what to do? So Now this guideline answers this question. So if the recurrent postmenopausal bleeding is there, then these patients require hysteroscopy and biopsy even with a endometrial less than 4 mm. Okay, so same thing is written here also. You can see it. This is the a screenshot from the guideline. This is a screenshot from the guideline. Okay, so women with the recurrent in postmenopausal bleeding, and though the ET is thin, less than 4 mm, but hysteroscopy and biopsy to be done for them as well. Now, another after ET is done, then next would be the endometrial biopsy. So next will be the like endometrial biopsy. It can be done again two ways. Two way blindly that we do in our OPDs using some suction device. So this will be like pipple or vibroaspirator. So this is the picture of pipple. It is very easy and simple. You just it is just like a syringe. You put it, you just scrape a little bit of endometrium, then you will find the endometrial tissue here. Apart from this, this is a blind procedure. Apart from this, it can be done under the hysteroscopy guidance also. So endometrial sampling device has got a false negative rate of 10 to 15%. This number is also important because this is also asked in the exam. Okay, now like what they say, if in the patient ET is more than 4 in postmenopausal bleeding and the endometrial biopsy is done, then it would be able to detect cancer in 95% of the cases. Okay, it will be able to predict it in the 95% of the cases. Now, best is the hysteroscopy, because in the hysteroscopy we are looking inside. So, I what the guidelines suggest, that if the hysteroscopy is done, it has to be done like outpatient. Okay, it has to be done outpatient, because these days we do have a office hysteroscope. They're very thin and small with a 2.7 mm, diameter is there. So even without, no, that doesn't require, you know any dilatation. And with that, even like hysteroscopy would be done. This is important number. Like what the evidence says, if the patient has positive hysteroscopy finding for the endometrial disease, including polyps, then there is a 70% chance of having endometrial cancer on histology. And if negative hysteroscopy, then only 2.5% chance of having endometrial cancer. These numbers will be important. Okay, so this I already told you that if the patient is presented with a recurrent postmenopausal bleeding, ET is less than 4, good idea would be to do hysteroscopy and biopsy. Even though the evidence is less, hysterectomy may be offered them as an option, because if the patient is having unexplained recurrent postmenopausal bleeding. Okay, so this is also there only in this guideline. Previously, when this kind of questions used to come, we used to answer them from talk. The specific guideline was not there, but this guidelines clarifies many of the things. Okay, any one of you have got any question till now?
I
Okay,
have a
no.
question, please. So
Yes.
COC, you mean reduce the incidence, I mean reduce the occurrence of endometrial cancer because it's inhibit ovulation. While HRT, it is all HRT because you mentioned even tubulon is associated with endometrial cancer. You mean HRT, even estrogen and progesterone, not only estrogen, only HRT. Why
No,
HRT leading to endometrial cancer while COC is reducing the incidence of endometrial cancer?
See. I wrote in the slide, HRT estrogen only.
only. What about
Yes.
Tibolon, doctor?
Okay. Tibolon has got, Tibolon is a man-made hormone that has got estrogenic effect, progesteronic effect, and anti-estrogenic effect.
Correct.
So it has got varying effect, and because of that, the Tibolon is also responsible.
Yeah.
Okay. And when in the young age we are speaking about COC, that time we are giving progesterone together with it. Because of that, it is protecting. Is it clear?
Yeah, yes, doctor. You mean it's estrogen only HRT rather than both
Yes.
combined? Yeah. Yeah,
Yes.
I get it. Thanks.
Okay. And now there had been so much changes in the classification of endometrial cancer. So this is the we are reading it from our undergraduate days. These are the histology diagnosis. Histological classification. But like endometroid carcinoma, and then serous, clear, mixed, undifferentiated craniosarcoma, unusual time gastrointestinal mucinous type. So these are the old classification, classification that we are reading. Now there had been updates. So now what they say, that there should be molecular classification, and there should be immunohistochemistry to be there. So on the now they are doing immunohistochemistry, and also they are doing genomic analysis. So on the basis of that, there is a new classification, molecular classification. And why it is important? Because it is more closely related to prognosis, and also it predict response to the adjuvant treatment. Only these are the two benefits. If they say why, then these are the benefits. This is a little now these are the few after immunohistochemistry. These are the four groups. They have put the endometrial classification. So this is the classification of endometrial cancer after immunohistochemistry. So they divide into four groups. This is ultra mutated pol mute and hypermutated mismatch uh, uh, repair deficiency, and copy number P53 high, and copy number is low, and these are NSMP, that is non-specific molecular profile. So these are the four groups. After the immunohistochemistry, they have put the they have divided the endometrial cancer in. Now these are the few characteristic of that. I have just put it just for the knowledge. I don't know whether they would be asked it in the exam. So first group is ultra mutated. Ultra mutated, that means less mutation is there, very ultra small mutations. Ultra mutated pol mute, this is like happens in 5%, and the woman is relatively younger, and they have a risk factor like diabetes and obesity. So if the mutation is there, there is a very small mutation, and the formation of and new antigen is there. Because of that, it happens. So this is ultra mutated. It is the pol mute. Group 2, they have divided hypermutated MMR deficiency. These are 25%, and they have got micro satellite instability, and usually they are linked with the link syndrome. Okay. 10% of this will be linked to the link syndrome. This classification is from the strategy. Group 3 is copy number P53 ABN, and they usually occurs in the older women. And yeah, high grade cancers occur here. The serous, uh, cranio sarcomas. So these kind of histopathology, they happen here. So this do have a worse prognosis. Another is non-specified molecular profile. Usually most 60% of the cancer lying here, and usually it is a diagnosis by exclusion, and predominantly endometrioid. And we already know that endometrioid have got the best um, treatment profile and as compared to the non-endometrioid. Okay, so this is the classification on basis of his immunohistochemistry, and this tables is from the strategy. I don't know whether it is important for the exam point of view and how they will ask the question, but yeah, this is the update. Now, if a patient comes with bleeding, so there has to have some, pre-operative checks, and before the patient is taken for any kind of treatment or some usually the surgery. So a physical examination, we already know about the physical examination. So like inspection, palpation, whatever. So PR, per rectal and vaginal examination to be done to find out the pouch of Douglas, adnexa, and ovarian masses, because usually like early granulosa cell or early ovarian cancer may be associated. Okay, these are the pre-operative workup thing, so that the patient going for the uh, like any kind of surgery should go ahead with. Apart from this, this is the staging assignments. This is what given in the BGCS guideline. What they say, chest X-ray is important, uh, is essential in non-endometrioid cancer such as serous, uh, uh, craniosarcomas of endometrium. MRI can be done. Why? Because much of the treatment for endometrial cancer, it is depend whether the how much the myometrial invasion is done, and that is a soft tissue. And for the soft tissue, we usually do MRI. So MRI is usually done to detect the degree of myometrial invasion. Apart from this, if any cervical involvement is there, apart from this, like any occult involvement is there, the patient having high risk histology or deep myometrial invasion, they should go ahead with a CT chest, abdomen, and pelvis preoperatively. PET scan can be done, but PET scan usually it is not evidence based to to be done all already. It is usually done to detect if any distanced metastasis is there, that is missed in the CT scanning, because CT scanning we are doing for the part only, the chest, abdomen, and pelvis, but PET scan we are able to find out the metastasis. Sometime you find the question from this, what kind of investigation to be done. So very basic and clear, we are doing chest X-ray or even the chest CT scan, because chest any spread is there or not, that is important. MRI for the soft tissue, and usually CT abdomen and chest if the locally advanced disease or the deep myometrial invasion is there. PET CT to find out if there is a metastasis is there, because that will not be able, we are able to find out in the routine scan. Okay, now this is the most, like, what should I say, difficult part they have made in the staging. Previously endometrial carcinoma used to be the best, for the like staging point of view, that was very easy. Now they have made difficulty in the staging also, it has become difficult. So this is the now staging. This is stage A, stage 1A. This is the very recent classification, came in 2023, this year only. Okay, so this is stage 1. So stage 1, uh, confined to uterine corpus and ovary. Now previously, you know this ovary was not there in stage 1. You guys would remember previously it was not there, now they have added this. Apart from this, stage 1, now it is ABC, divided into 3 part. Now coming to A, again they have divided into A1, A2, and A3. So A is like limited to endometrium, limited to endometrium. Apart from this, low grade, limited to endometrium, that means less than half of invasion. So somebody's mic is on. Please, all of you, mute yourself. So, stage A, Previously also it is less than half of myometrial invasion is there. So same is there. So A is limited to endometrium, non-aggressive tumor. Apart from this, less than half myometrium, no lymphovascular space involvement, and good prognosis. So if you see now, these days when you will solve question, apart from looking at the stage where it is spread, you have to see whether the tumor is aggressive type or non-aggressive type. New FIGO has classified the this histological classification into two parts: aggressive one and non-aggressive one. I'll be showing them later. So whenever you see your question, please see whether you are dealing with the aggressive pathology or non-aggressive pathology. And another clue is this, that this aggressive and non-aggressive, usually in the new staging they have used in stage 1 and 2 only, and it will come in C. The moment you see aggressive, so it will be in the C only. So stage 1A is non-aggressive, less than half myometrial invasion. Now they have divided again this into 1, 2 and 3. So A1, when it is limited to polyp, endometrial polyp or endometrium only. If the LSVI they are saying, so non-aggressive pathology less than half, and with no or focal LSVI. Basically, you will find in staging there is a substantial LS LVSI involvement. So if the more than 4 vessels are involved, then they consider that as a substantial. But here they are saying I either no or focal, maybe very small. Okay, LSVI. Stage 3 is like low grade endometrioid, but here the ovary has come, uterus and ovary has come. Now how ovary usually it is involved in the stage 3. Now they are saying in the stage 1 also. So ovarian involvement in stage 1 and stage 3 is different. In upcoming slide I'll just explain also that how you will put the patient in stage A if the ovary is involved, and how you will put the patient in stage 3 if the ovary is involved. This is also a new thing in this guideline. So if you see overall, uh, stage 1A is less than half invasion, and so A1, A2, A3. A1 will be limited to endometrial polyp or confined to endometrium. A2 is less than half or no or focal LSVI. A3 is here the uterus and ovary also has come. B1 is like previous B also. It is more than half of myometrium involved with no or focal LSVI. Focal LSVI, okay? And aggressive pathologies will come in 1C. So aggressive histological types either limited to polyp or to confined to the endometrium. So this is all about stage 1A. Is it clear, people? Stage 1A. Staging is difficult now. Any question? Okay. Now stage 2. Stage 2, we already know it is like involvement of cervical stroma. It is involvement of cervical stroma with extra uterine extension or with a substantial LVSI or with the aggressive histopathology. Okay. So again, so three word you have to remember: extrauterine extension, involvement of substantial LSVI, or aggressive histopathology, aggressive type of histology. Okay. Now A is involvement of cervical stroma. Again, it will be non-aggressive. As I already said, aggressive will come in C only. So cervical stroma involvement, non-aggressive tumor. Two things. B will be LVSI, substantial, that means more than 5 vessels are involved. So a substantial LVSI of non-aggressive type again. So stage 1 and stage 2, sorry, 2A and B. A and B will be non-aggressive type. Now the moment you move to C, it is aggressive type. So aggressive type with any kind of myometrial involvement. So basically previously also it was involvement of the cervix only, but now they have more specified it and divided into A, B, C. Again, I'm repeating, A is involvement of stroma, cervical stroma. Second is involvement of uh, LVSI, that is substantial, and C is aggressive pathology. Now, the most worst classification they have made to the stage 3, so much changes. So again, previously also, it was it had 3 parts, but now they have made even the sub parts of that. So like and here now you can see local and regional spread of any histology. In stage 3 they are not mentioning whether it is aggressive or whether it is non-aggressive. So any histology, any type of the histological tumor could be there. So 3A will be like serosa adnexa. So that means the cancer has moved out to the uterine serosa and also to the adnexa. So they have divided this into one and two. So one will be ovary and fallopian tube, and two will be uterine serosa, subserosa or serosa. Okay. So this is the A1 and A2. So this is a change. So A1 is ovary fallopian tube, A2 is uterine subserosa. Again, 1B, 1B it was like spread to vagina and perimetrium or pelvic peritoneum. Previously also it was vagina and perimetrium. Now they have divided into 1 and 2. One will be vagina perimetrium, and two will be the 1B2, sorry, 3B2 will be the peritoneum along with it. So vagina, then it is pelvic peritoneum. Now 3C, 3C previously also it was pelvic and paraaortic lymph node or both. So C1 and C2. So C1 will be related to pelvic lymph node. It do has two type of further subclassification. C1 1I will be micrometastasis in lymph node, and C, 3C1 double I will be the macrometastasis. Same with the C2, it is pelvic in para-aortic lymph node. So C2 is para-aortic lymph node up to the renal vessels. So this part is important because there is a change in the staging in that. So metastasis to the para-aortic lymph node up to the renal vessels, with or without metastasis in the pelvic lymph node. Okay, and this is a sub classification is one eye is single eye is the micrometastasis, and double eye is macrometastasis. So there are too much changes, but if you read it calmly, you will find it is almost similar to the previous one only. But yeah, some sub classification has come. Is it clear?
Yes, ma'am.
Okay, so this is the like same stage 3 what from the FIGO. Now with this part I was speaking. So ovary has come in stage 1 also, and ovary has come, ovary is there in stage 1A3 and stage 3A. Now how we can differentiate this? So these are the criteria. A1, like our first stage, there will be no myometrial invasion more than 50%. There will be no LVSI. There will be no additional metastasis, and there will be unilateral involvement of ovary without capsule invasion or rupture. So if these criterias are there, then the classification will be stage 1A3. And if these criteria are not present and ovarian involvement is there, then stage will be 3A1. So these are the few new things again to this guideline. This part I have already explained, that the substantial LVSI when more than 5 vessels are involved. Now stage 4. Stage 4, like it is same, there is no too much changes not there. Involvement of bladder, bowel, mucosa, and distance metastasis. So A is nearby structure, that is bladder mucosa, intestinal mucosa, and B will be the beyond pelvis. B for beyond pelvis, 4B is beyond pelvis, and C will be metastasis to extra or intra abdominal lymph node above renal vessels. Okay, so in 3 we have read it was up to renal vessels. Okay, so 3C2 was involvement of para aortic lymph node up to renal vessels. Now this is a change here. So here, if they say that in your question, metastasis uh, above the renal vessels, involvement of lymph node above the renal vessels, then your answer will change to 4C. Okay, and involvement of like distance metastasis, 4C is the last one. You already know lung, liver, brain, bone, everything will be involved. So these are the updates in the FIGO staging 2023. Is it clear till now? Should I move ahead? Because a little more complex things are coming. Okay, now a few things. Again, though it will be the repetition from the previous also. This is all FIGO 2023 is going on now. So we already this is like common thing. We know that the endometrial cancer is surgically staging is done and the pathology is also examined. Now, as I have already discussed about the molecular classification, so according to them, molecule apart from the looking at histology, LSVI has to be recorded. Apart from this, if the facilities are there, then molecular classification to be done. Then the molecular classification to be done. Apart from this, usually in early endometrial cancer, standard surgery it is a hysterectomy with salpingo-oophorectomy via laparoscopy, because now the approach has changed. Okay, but it would staging will include infracolic omentectomy if serous undifferentiated endometrial carcinoma, craniocarcinoma is present because they have got macroscopic omental metastasis. This all are updates from the FIGO. Okay, and lymph node staging should not be done in the low risk disease, but high risk the patient, the lymph node staging to be done. Now this I was already speaking. In revise FIGO staging, the tumor they have divided into two parts. Non-aggressive is low grade endometrial carcinoma, and all other clear cell, serous, mucinous, undifferentiated, craniosarcoma, and mesonephric like gastrointestinal mucinous carcinoma, they have put in the aggressive. So this classification is important to know, because now you can understand that in FIGO, new FIGO, stage 1 and stage 2, the staging is done according to this classification, aggressive and non-aggressive, though it doesn't matter in stage 3 and 4. Okay, apart from this, molecular profiling is done. I already told this, that to find out the prognosis. Okay, like pole mute that was ultra mutated has a good prognosis, excellent prognosis, but ABN has a bad prognosis. P53 ABN has a bad prognosis. Apart from this, those who are lying in a non-specific group, if they have got like estrogen negative, they also have got a bad prognosis. So usually this profiling helps in finding out the prognosis, and also response to the adjuvant treatment. Now this is again from the this guideline, this the staging appears to be very complicated, uh, but it has come. So I don't know, like you may get question. So this is with the FIGO endometrial cancer staging with a molecular classification. So if they are doing molecular classification, so they will add the suffix m. Okay, apart from this, whatever the classification is there, they will add this, like stage 1a molecular pole mute. Apart from this, stage 2c molecular p53abn. Okay, so this way they are adding the suffix again. uh, uh, these are the, this part may be asked in the exam, at least this much it is important to know. So pathogenic pole mute mutation have got a good prognosis, because when we were reading from the groups, it was ultra mutated. So ultra mutated, that means less mutations, that means good prognosis. Apart from this, intermediate prognosis will be um, like MMRD, mismatch repair deficiency, and microsatellite instability, and non-specified group. They had a good prognosis, because we already know that 60% of the non-specific molecular profile cancer, they are endometrioid. So they have intermediate prognosis, and P53ABN has got poor prognosis. So everything is remembering difficult, but in my opinion, at least this much you should know, that if any question ever comes in any of your exam, you'll be able to speak about the prognosis, because it is more related to the prognosis. Now this is again a very sort of a complicated thing, though I have already explained it. I'll explain it again. Now what the FIGO says, stage 1 and 2. So if the molecular classification is there, then this suffix will be added. So it will be appear like M Polmute or M P53ABN. So this, they are saying, they're explaining how to put the suffix for the classification. Apart from this, what they say, MMRD and NSP, uh, usually they will not modify any prognosis in early stages of cancer, that is stage 1 and 2. Ideally it should not be done. Okay, and if it is done, then the staging, it should be written like then that M for molecular, and this is non-specific molecular profile, and M is for molecular, and this is MMRD. So for stage 1 and 2, ideally they recommend only two type of thing to be done, that is polmute and P53ABN. And I just explained that polmute will have good prognosis and P53 will have like bad prognosis. Okay, so this is about stage 1 and 2. Stage 3 and 4, it depends on the surgical finding, and it is not modified. 3 and 4, they are not modified by the molecular classification. But so ideally it should be, if it is done, then it can be recorded, and recording is done with this kind of situation, like M will be put and PB3VN, or like here M is put in stage 4 and P53ABN. Okay, so this is the details that are given in the FIGO classification. So this is all about FIGO. So any one of you have got any question till now? Though this is sort of a complicated, I tried from my side to simplify it. Any question till now? As the guideline updates are coming new in 2023, so question you will start seeing in the upcoming exams. Any question? No question. Okay, now some few exercises. So a patient has gone.
Madam, excuse me.
Yes, yes.
Madam, this guidance is a little bit different. So, should we also read the previous guideline with that?
No,
I
in
think
my
so. It's
opinion,
enough.
see, if I have put all important things that is necessary for the exam from the FIGO also, from BGCS also. But if the classification has changed, and
Yes,
if
ma'am.
the
Staging
staging
is.
has
Ji, ma'am.
staging has changed, so question will appear, should appear from the new only. Why they will put old thing?
Yes, ma'am. Because in exam a lot of things get messed up, so it's very lengthy course. I think so. It's better to read only this one, the new one. That's why I'm asking.
Yes, otherwise you will make mistake, getting confused both ways.
Yes, ma'am. Like that of interpartum guidelines. So much confusion because the CTG is changed in the new one. Sometimes we
Yes,
forgot. Thank you, ma'am.
it is very good. Those people who have read from the previous guidelines and the new guideline, there is too much of problem for them.
Yes, ma'am. Yes, ma'am. Anyways, thank you, madam.
Yeah, nothing can be done for that. So I myself, when I started prepare for the exam, that time colposcopy 2010 guideline was there. So I read that guideline, that was 80 pages. Just before exam, 2016 guideline of colposcopy came. Then I remembered that also. And now to 2020 February, it came in 20 also. So three colposcopy guideline I have read. So there is a utter confusion with me. So it
Right,
happens.
madam. Colposcopy is also confusing, but I think so. 2020 guidelines is enough. I read only
Yeah,
that
yeah, yeah.
one.
That is a
I
very small guideline. I have read previous guideline that has like 110 pages. Now it is
yes, ma'am.
easy.
Yes,
Previously it
and
was difficult.
yes, ma'am. I think that this guidelines is more than enough for the previously endometrial
Yes,
guideline is very short as compared to this, the other
yes,
CS, but now it's also extensive. Thank you, madam, so much.
yeah. So this is FIGO is also so difficult. I read many times to before I just put this. Difficult to understand. FIGO has made. Okay. Now some small questions. So patient has gone TLH, BSO. She has got endometrial cancer. Histopathology shows carcinoma confined to inner half of parametrium. Sorry, myometrium. Peritoneal washings are positive. What you will say? What is the stage?
1A2, ma'am, because inner half of the myometrium.
Yes, very
But
good, excellent.
yes, ma'am.
So again, so this way, but while doing questions, you will remember this. So now, like A1 will be related to polyp and confined to endometrium. Less than half, less than half is A2, and if the ovary is involved, then it will be A3. Okay, so the, yeah, very good answer. Another question I want to just say about the peritoneal washings. So in this new guideline, they have put nothing about the peritoneal washings. Previously, you will find the question where the staging used to change about it. Apart from this, there is another thing to know, that sometimes hysteroscopy is done before we are able to diagnose cancer, and we are using saline. And if the tubes are patent, some they used to say previously that some of the cells will break, and from the the tubes, it will go into the peritoneum, that will cause the upstaging, or peritoneal washings may come positive. So there was a little debate about it. But in the new classification and new there is no place if the peritoneal washings are positive and negative. So if you find this in your question, that you have to just don't need not to pay any attention to this. And according to the available evidence, if the hysteroscopy is done in the endometrial cancer beforehand, it will not upgrade the disease. Another question. So same question, but final histopathology report is now clear cell carcinoma. It is confined to inner half. Peritoneal washings are positive. What is the stage? Anyone?
1A3, ma'am, because clear cell carcinoma is
Very
a
good.
high grade.
Very good. So this
Yes.
message I wanted to give you: whenever you find a question from stage 1 or stage 2, please look at the pathology, whether you are getting aggressive and non-aggressive. The moment you see aggressive, you can put C, because 1C and 2C, two classification has got aggressive pathology. Okay, because of only this I made this question. Very good. Now the patient
Right.
at the time of hysteroscopy, abnormal lesions in the uterus and also in the upper part of vagina, and MRI scan doesn't shows any spread. Biopsy of lesion shows endometrial carcinoma. So what will be the stage? What is the
Ma'am,
clue here?
3B1, ma'am.
Yes.
UB1. Endometrial
Vagina
UB1.
is, yes, 3B1, because vagina is 3B1 and pelvic peritoneum is 3B2. Okay. So this way it is important to this way you will remember the staging. B1 is vagina and parametrium. B2 is pelvic peritoneum. Now poorly differentiated cancer invaded more than 50%. What is the answer?
Once, 1C, ma'am, it is poorly 1B.
No, no.
1C,
Ideally, ideally it should be 1C because it is
okay,
poorly differentiated.
okay, ma'am.
Yeah, where we are. Yes. So because it is poorly differentiated, so answer will be 1C.
If it is not poorly differentiated, it will be
Then it
1B.
will then it will be 1B.
1B, invaded more than 50%. Yes, yes, ma'am.
Yes. So now in this new classification, histopathology is making change in the answers. Now, well differentiated carcinoma, and there is a large pelvic lymph node and contain metastatic cancer, no evidence of distant metastasis.
Ma'am, 3C1, ma'am.
Yes, C1, why? Because it is a pelvic lymph node.
Hmm.
If it is pelvic lymph node, C1, just remember this, small is micro and macro only. And if it is para-aortic up to renal vessels, then it is C2. So now this way the life will be easy, a little easy to remember. Now again, this is management of endometrial cancer, and this is all management I have written from BGCS guideline. Okay, staging, all part of staging what we have learned is from FIGO 2023, and all cancer treatment part is from BGCS guideline. Okay, now what they say, treatment of stage 1. So treatment of stage 1 is standard treatment is total hysterectomy with BSO. So this is total hysterectomy with BSO. But if you find the patient is young and the fertility preserving surgery is required, then it will be hysterectomy with selfingectomy with ovarian conservation. And where it could be fertility sparing surgery can be done if grade 1 endometrial carcinoma, if it is grade 1 endometrial carcinoma, less than half invasion and no extrauterine disease. So this is sort of a new update that was not there previously there. Okay, apart from this, now okay, I'll just speak about it now. About the routes of surgery, in previous days it was total abdominal, as we know, but now the disease, now the era has changed. Now the approach has become minimal access or laparoscopy, because we already know that laparoscopy what benefits it had, like lower risk of post-operative morbidity. So laparoscopic hysterectomy, it is more feasible. Apart from this, new addition, new update is about the robotic surgery. So robotic surgery can be considered, it has got it, no, it is appears to be non inferior, like to laparoscopy and laparotomy. Like it can be done, but if you consider in form of benefit, so benefit is not there. But apart from this, long term data is also not there that support robotic assisted surgery. So these days usually laparoscopic route is preferred. Now apart from the lymph node updates, so usually in low risk cancer, lymphadenectomy for non-bulky lymph nodes is not recommended. Okay, this part you have to know, that lymphadenectomy for non-bulky nodes is not recommended. But what can be done is the sentinel lymph node biopsy. So I'll just give a brief idea. Usually what they do in sentinel lymph node detection, they put some dye, and then they have got a tracer machine. With that they usually check the first node to be involved. If the node is not involved, first node is not involved, draining first node is not involved, that means all nodes are not involved. So with doing this, they are able to find it out, whether the lymphadenectomy should be done or not. So usually for non low risk endometrial cancer, lymphadenectomy should not be done. But sentinel lymph node biopsy uh, can be done, because it should replace lymphadenectomy in non-bulky lymph node disease. Okay, apart from this, it is less supporting evidence. The consideration for omental biopsy may be considered, but it is not they are recommending. Okay, so this few things you should know about the lymph nodes. Now, okay, so same thing. This is from the FIGO and this is from your BGCS guideline. So what the FIGO says, sentinel lymph node biopsy is adequate to the systemic lymphadenectomy for staging purposes. Almost the similar kind of thing. So it can be considered in low risk patient, low risk patient. Okay, so this is endorsed by all European guideline to do sentinel lymph node biopsy in the patient of endometrial carcinoma. So this is supported by Europe and also endorsed by FICO. So it is a good alternate for systemic lymphadenectomy in high, intermediate, and high risk case, for the cases of lymph node staging. So like this is all about the lymph node biopsy that has come by the this is by the BGCS, and this is by the FIGO 2023. So ideally the take home message, that in low risk or low risk cancer, the sentinel lymph node biopsy can be done, but the lymphadenectomy should not be done. Okay, now this is all about the stage 1. I'm speaking about the primary treatment, the first treatment we do to the patient. Now the primary surgical, we are speaking about surgical treatments. So treatment for stage 2. Stage 2, we already know the cervix is involved. So either it will be total hysterectomy with bilateral salpingo-oophorectomy. Okay, total hysterectomy with bilateral salpingo-oophorectomy, this is the usual thing. Radical hysterectomy can be considered to obtain free margin, because we know that the cervix is involved. We already know that cervix is involved in stage 2 cervical stromal invasion, and we have to kind of, if we want to remove whole of the thing and we want cancer free margins, then radical hysterectomy can be done. We already know the difference between total hysterectomy and radical. In radical, the all pedicles, they will be cut at the source, and a part of vagina will, lower upper third of vagina is also taken out. Okay, so this is all about stage 2. The treatment of choice will be hysterectomy with BSO, but consideration for radical hysterectomy to obtain free margins. Stage 3 and 4 disease, we already know that it would be a big spread. So usually what they say, so it should be debulking surgery, including bulky lymph nodes. So that's all about. So there should be debulking surgery with bulky lymph nodes with complete microscopic resection. That means whatever the cancer, you can see, you can resect it. So it is macroscopic resection possible, but this could be like huge surgery to be done if the patient is fit for it. If the patient is not fit for it, the surgical option, then they can be offered alternative options also. Okay, so this is the this usually is done in stage 3 and stage 4 disease. Now these were the surgical treatment for uh, for the as a primary treatment for endometrial cancer. But sometime, you have a patient will come and the patient is not fit for the surgery, or what will be the primary treatment, non-surgical options. So it would be like these are the few things that have been given. So if the hysterectomy cannot be done by laparoscopy or abdominal approach is not possible, even the vaginal hysterectomy may be considered. So vaginal hysterectomy, even the surgery is not possible, then they can offer radiotherapy. So radiotherapy will be external beam radiotherapy, that is from outside, and brachytherapy, it is put inside the vagina, that is the intracavitary brachytherapy. So this radiotherapy can be done. But if the patient has got low grade disease, then instead of doing combination radiotherapy, only intracavitary brachytherapy can be done. So this is about the radiotherapy as an option. Last option is progesterone. So if they want to postpone the surgical treatment, or for the medical reasons, or the patient is not fit for the surgery, even the progesterone can be given for 3 to 6 months. In postmenopausal women, where surgery and radiotherapy both are not as the option, consideration for progesterone and even the aromatase inhibitors can be done. So these are the primary treatment for the endometrial cancer when the surgery is not feasible. So these are the alternate. So this will be very important for part 2 and part 3 both people. Now this guidelines really clarifies all this treatment part. uh, so apart from this, fertility preserving treatment, that like fertility preserving treatment, uh, it can be done only surgical part I have already explained. It can be done in stage 1A when the myometrial invasion is not there. So what kind of treatment apart from surgery, what could be the non surgical treatment? It could be medroxyprogesterone acetate. So it will be medroxyprogesterone acetate. This is stage 1, 1A, grade 1A cancer without myometrial invasion. That means no myometrial invasion. Okay, no myometrial invasion. Okay, so according to the new classification, 1A1 will be the grading, because there is in 1A1 usually it is confined to endometrium or the endometrial polyp. We just read it now. So in the according to the new guideline 1A1, uh, what could be the possible treatment alternative for the women who are looking for fertility? That will be progesterone. So it is medroxyprogesterone acetate, that is 400 to 600. Now you can see the doses are very high. Doses are very high. Medroxyprogesterone acetate, 400 to 600 milligram, or it could be megestrol acetate, 160 to 120 milligram per day, or it could be LNG IUS for 6 to 12 months. Okay, so these are the few things you should know may come in the exam. Apart from this, sometimes even hysteroscopic resection of can be done when this when this therapies are done, because some part of the endometrium, it will be taken by the hysteroscopy. Then for rest of the left out condition, so this treatment can be offered. Apart from this, there should be strict surveillance, repeating imaging at 3 monthly interval, because we are going for the fertility sparing. There could be possibility it may progress. So imaging 3 month after the disease has like regressed, 6 months of that, progesterone maintenance therapy can be. Now the disease is regressed, so some maintenance therapy can be done till the patient want to delay the pregnancy. Surveillance of endometrium first by 3 to 6 months, or by scan, and then 6 to 12 months. Okay, so progesterone therapy may be considered for intrauterine recurrence, and once the like hysterectomy and bilateral self-hysterectomy can be considered if the conservative measurement fail. That we read in the surgical treatment. So in this patient, for if the patient like young patient fertility, they don't want to go ahead with the surgery, this kind of treatment with the progesterone can be done. But if it is still not responding, then the patient can be counseled for the surgery. What can be done? It could be hysterectomy with self-hysterectomy bilateral with the ovarian conservation. So if the ovarian conservation is there, then by the IVF and the surrogation, she can get pregnant. So you may get in the exam some twisted question from the fertility preserving patient having stage one grade one endometrial cancer. So these are the few options that you have to remember. Any question? Okay, now these were the surgical treatment as primary treatment, non-surgical treatment as a primary treatment. After the primary treatment is done, there would be adjuvant treatment. Adjuvant treatment is always for the left out disease. Okay, so which patient requires adjuvant treatment? How to decide that? That will depend on certain prognostic factors. What is the histology? What is the grade? What is the depth of myometrial invasion? What is a LVSI? What is the lymph node metastasis or molecular classification? So these are the prognostic factors that would decide whether the after surgery adjuvant treatment is required or not. Now again, they have made the life more complicated. So adjuvant treatment, for the adjuvant treatment, some this is the this classification is there. So in this classification, uh, like previously we used to decide on these factors whether the patient requires adjuvant treatment or not. Now what kind of adjuvant treatment patient to be given, so they have decided them, put them in these groups. Previously also these groups were there, low, intermediate or high risk groups were there, that were like depend on the risk factor. But now they have divided them into the stages. So this is the table, and this is the, like I try to a little simplify it. So when the histopathology is done, when the staging is done, after that, for the adjuvant therapy, this kind of classification will come. So this low risk group will be stage 1A, G1, G2. Intermediate will be a little higher. So stage 1, grade 3, stage B, G1, G2, and stage 1A, non-endometrial. This was not there previously, though this classification existed, but non-endometrial stage 1A has been added. Apart from this high intermediate, it will be any stage 1 with LSVI, stage 3, grade 3, and stage 2. So stage 2 cancer has come here, high intermediate. And high will be 3 and 4 without any residual disease, or any from 1 to 4A non-endometrial with myometrial invasion and no endometrial disease. And stage advanced risk will be the like high risk. I don't think so. This is needed to be remembered. Just you should have a rough idea about it. So, what are the prognostic risk groups? Low, intermediate, high, and advanced. Why it is important? Because adjuvant treatment uh, will depend on this risk groups only. So now, low cancer, low risk endometrial cancer. So we already know what is the low risk endometrial cancer. So this is stage 1A, G1, and G2. So what they say, low risk, no adjuvant treatment is required. So you get this question in the exam. They will give you this, like the patient has the stage 1, grade 1 disease, then you will say it is a low risk and no adjuvant treatment is required. Okay, this part I have already spoken. If the molecular classification is there, if the pole mutant tumors are there, they have got good prognosis. So usually they represent it in a group where adjuvant treatment can be withheld. That means not necessary. So you will get question from here: low risk or pole mutant tumors, no adjuvant treatment is required. Now intermediate risk. So intermediate risk, these were the intermediate risk stages. Intermediate, that means a little higher. So stage A1, then grade 3, stage B1 starting, grade 1, grade 2, and stage A1 non-endometrial. So what kind of treatment can be given? It can be given vaginal brachytherapy. That means only from the vaginal route they are giving radiotherapy. Okay, so VBT or vaginal vault brachytherapy can be given. And if the patient is in this group, but if the patient age is less than 60, or if the disease was restricted to the polyp, then only with the only surveillance will be only okay for this kind of patients only. Okay, apart from this, polymute are low risk, and PBN, A, P53 ABN are high risk. Okay, this we have already known. So if the PBN is there and it is restricted to polyp without invasion, usually adjuvant therapy that time may be individualized because it
Madam,
is restricted to polyp only. Yes.
yeah. Madam, pole mount is also is genetic, just like PT53. I forgot pole.
No, Paul mute was ultra mutated and very minor mutation, and they have got very high, very good prognosis. So they are low risk.
Right. Just like
Okay.
T53, but it has a very high mutation.
Yes, it is a
T53
very high.
tumor suppressor gene, yeah.
Yes, it has a very high risk.
Yes, ma'am.
So in intermediate, these kind of stages, this is the this would be the adjuvant therapy. Now, high intermediate risk. What is the high intermediate? High means it has reached till vessel, LSVI, and grade 1 G3. Now, here it was grade 1 G1, G2. So, if it is G3, then it becomes high intermediate and stage 2. Stage 2 has been included. So, I try to simplify it like this so that it becomes easy. So what could be the like adjuvant treatment? It would be external beam radiotherapy, plus minus vaginal brachytherapy. And if they find that nodes are not there, then only vaginal brachytherapy can be done. But if it is extensive LSVI, that time even the chemo would be required. Time the chemo would be required. Okay. So this is adjuvant treatment in high intermediate risk endometrium. Now, high risk cancer group will be stage 3, 4, and A with residual disease, without residual disease, and non-endometrioid with myometrial invasion. That high risk only. In high risk, again, either external beam radiotherapy or vaginal brachytherapy or chemo would be required. Now, this is the like a summary of the treatment, adjuvant treatment. So, if in spite of remembering all these things, if you could remember this table only, then your life will be easy. So that was the detailed explanation of this tumor. So let me repeat it again: low risk group, no adjuvant treatment. Usually, you find question from these two. Intermediate risk group, yes, what either vaginal brachytherapy, surveillance only is the option if the disease confined to polyp of or if the age of the patient is less than 60. High intermediate group, EBRT and VBT, uh, so if the particularly if extensive LSVI and stage 2, because it will be like advanced stage. And if they have done the nodal dissection, and if the nodes are negative, that means no spread of the disease, then only local treatment, vaginal brachytherapy is required. But if it is extensive LSVI, then consideration for chemotherapy. High risk group, again high risk, we have to give all thing, EBRT plus minus VBT and chemotherapy with carboplatin and paclitaxel. Okay, so at least remember this adjuvant treatment. Minimum this much would be necessary to answer your question. But usually the question comes from the above two groups. Question usually comes from here. Now, uh, adjuvant chemotherapy. So, so what they say in adjuvant chemotherapy, adjuvant chemotherapy, it could be like carboplatin and paclitaxel, and usually it is given in these kind of conditions. Okay, my like stage 1 and 2, clear and serous. So we already know from previously also, said that like clear cell and serous usually the chemotherapy would be required. And stage 3 and 4A, these are the stages where the adjuvant chemotherapy is required. So this would be the staging when they have not done molecular subtype. But if the molecular subtype is done, then these are the stages where chemotherapy is required. Myoinvasive 1 to 4, where they have got abnormal P53, clear and serous. Stage 3 and 4A were non-specified. Okay, so this is the adjuvant chemotherapy. Only this much is necessary for you, need not to remember or much. So adjuvant chemotherapy for these stages: microinvasive stage 1 and 2, clear and serous, and stage 3 and 4A. So the similar kind of thing is there. If the molecular classification is there, then this would be the change. This is adjuvant chemotherapy. Usually, previously and now also, we have read that in endometrial cancer, usually first treatment would be surgery. This will be followed by adjuvant radiotherapy. But there are certain situations where adjuvant chemotherapy is used, and these are the situation. Okay, now this is again given in this guideline. For adjuvant treatment, hormonal therapies are not given. For adjuvant treatment, hormonal therapies are not given. Now, radiotherapy we have discussed, and what are the technique is used? That is the IMRT, to decrease the long-term and acute toxicity for radiotherapy. You may get question from this IMRT. Now, a very small portion I have put about that. EBRT, that is the external beam radiotherapy.
Madam,
Usually,
this is the same thing which I also we have also mentioned in the cervical cancer, I think so. IMRT and techniques.
yeah. This is the name of a technique only.
Yes,
This is
ma'am.
name of a technique.
Technique, yeah,
This
ma'am.
is yeah. This is
Radiotherapy.
radiotherapy technique. Yes, but question comes from here, so I just highlighted it.
Okay.
So EBRT, like external beam radiotherapy, this is either IMRT. What is the full form of IMRT? Intensity modulated radiotherapy. Another technique is uses VMAT. So this is like either IMRT or VMAT. Apart from this, why we are using all these techniques? Basically, when the radiotherapy is given, then apart from the cancerous tissue, normal tissue will also be affected. So these are the new techniques because they want to increase normal tissue sparing and decrease toxicity of radiotherapy. Okay, so these are again VMAT and IMRT. So VMAT, full form of VMAT will be volumetric modulated arc therapy. So these are name of techniques only, and this is the dose: 55 to 40, no, sorry 45 to 50.4 gray in 25 to 48 fractions over 5 weeks. No need to remember these doses. Nobody is going to ask you. Just an overview I wanted to give, and I have to complete this guideline also. So this much knowledge about EBRT is, is enough for you guys. So another, if the local disease is there, low grade disease is there, then we give this vaginal brachytherapy. Usually vaginal molds are made that are put into the vagina, and it is, so you can see it. What will be the target volume, and these are like 21 in 3 fractions or 24 gray in 4 fractions. So this way, like brachytherapy is given. Again, I have never seen, question from this. Only about the technique I have seen and why it is used. This much knowledge, in my opinion, is enough. Now another, sometime the disease is very advanced. So in, if the advanced disease is there, then in many of the cases, new adjuvant chemotherapy is given. What is new adjuvant chemotherapy? That when the chemotherapy is given before we do surgery. So first the chemotherapy is given, then some time is spared in between, so that chemotherapy can act. That will usually decrease the cancer volume. After that interval, debulking surgery is done. After that interval, debulking surgery is done. And where NECT followed by debulking is done, when the disease is advanced or the patient cannot is not fit for the surgery. And what will be the chemotherapy regimen? That we already know, it is carboplatin and paclitaxel. But if the hormone receptor positive tumors are there, consideration for even progesterone can be done, but it is not used. Basically for NACT, carboplatin and paclitaxel is used. So first they will give chemotherapy, then there would be some interval. After that they will do debulking surgery. This is the options for the primary treatment when the disease is advanced. Now sometime primary treatment will be directly radiotherapy. When the unresectable disease, distance metastasis, like see the patient, already the patient is in advanced 3 or stage 4A, what you will do? Surgery is not possible. That time even primary radiotherapy can be given. Primary radiotherapy, okay, where it will be EBRT followed by, where it will be EBRT to pelvis followed by image guided brachytherapy. This question also I have seen in the exam. What can be given before first, brachytherapy or EBRT? Now this solves the question, that EBRT to pelvis followed by brachytherapy. This question I have seen. Now, if the recurrence is there, you already know, we already know the cancer recurs. So, if the patient come with a recurrence, then what to be done? There should be multidisciplinary team meeting. There should be imaging to find out, uh, where it has spread, and there should, if the possible biopsy is done, and PET-CT is done. PET-CT, you be a little idea I had to give out the PET-CT. PET-CT is an investigation where usually 2 FDG glucose. This is injected, and usually it will accumulate in the metastatic area. Then whole body imaging is done. So with this, wherever the metastasis is there, we are able to identify it. So this is about the PET-CT, because many times I have seen questions and the people are confused, about the investigations also. So some information as the advances is there already in the medical science, so everything you should know. So PET-CT is done for the distance metastasis, and also the chemical that is used is the 2-FDG. Now if the recurrent disease is there, what you will do? Now if the patient uh,
Madam, I asked question.
hmm,
Madam, actually the
yes.
question mostly comes in because that what is the main investigation for the recurrent disease, PET-CT, CT scan. But in recall we do CT scan because PET-CT is for the, as you have previously said, surgical resection and radiotherapy. After that, go for PET-CT. That is the always confusion there. What is the management of recurrent disease? Anybody other know this recall?
So I don't know about the recall, but what the guidelines is, I can speak about that. See if it answers your question.
It,
So in
not. What are the investigation for the recurrent disease, especially for the high grade sarcomas? Question is that.
sarcoma,
Yes, ma'am.
so what were the what were the what they gave as an option?
And PET CT and CT scan and main type in between these two. Other investigation I forgot, um, uh, but
Hmm.
main uh, confusion in between these two, PET CT or the CT
CT
scan.
scan
Yes,
or
ma'am.
sarcoma.
Yes, ma'am. For
Okay.
sarcoma, and sometimes also there is a also the for the investigation of recurrent endometrial cancers.
So the recurrent endometrial cancer is the PET CT only.
Right, ma'am.
Best is PET
Right.
CT. That is PET
Okay.
CT. For
Right.
the recurrent sarcoma, I'll look into it and I will tell you.
Thank you, madam. Thank you.
So, a recurrent disease. Now, what is the treatment? If only vaginal recurrence is there and a radiotherapy naive, that means previous radiotherapy was not given. Naive means not given already, or patient has never received radiotherapy, then patient can be given radical radiotherapy. Okay, so if previous treatment is by surgery, no radiotherapy has been given, so we can consider giving them radical radiotherapy. If the patient has got vault recurrence and they have received radiotherapy first, then they can be considered for surgery if the resection is achievable. From these lines, many times you will find question. So if the previous treatment with the surgery and the radiotherapy was not given, so best idea to be treat now with the radiotherapy. If your second situation, if the patient has got a vault disease only, local disease, and previously radiotherapy was given, so now if the resectable disease is there, then surgery to be done. Okay, so from there you get questions, and the patient who are treated for pelvic recurrence surgically, and if they have positive margins, then they have, if the positive margins are there, then they had to go for radiotherapy only if it is possible. So I'll repeat it again. If the first treatment by surgery, then you can consider giving radiotherapy. If previous treatment by radiotherapy, then you can consider doing surgery if the margins are resectable. And if that surgical treated disease, if the margins are positive, now you try to do the surgery, but the margins are positive, again you have to consider giving them post operative radiotherapy or brachytherapy. So I think with this you'll be able to answer your recurrent disease questions. Now this is again for recurrent disease. If low grade and hormone estrogen hormone receptive disease is there, then hormonal therapy can be an option. If lung metastasis is there and high progesterone receptor expression in the tumor, then they can be this receptor is the progesterone receptor. So in that situation, primary hormonal therapy can be done. Now many times you will find the question, there would be a big scenario and they will say that it is already spread to the lung, so that means the lung metastasis is there. In that situation, and the hormone is progesterone receptor positive, answer will be hormonal treatment. This question also come. Okay, one thing to remember, that when I was speaking about the adjuvant treatment, in adjuvant treatment hormone treatment was not the guideline recommending, but for recurrent disease, low grade hormone receptor positive, they are considering hormonal treatment. Okay, so and whenever you find this kind of scenario where the lung is involved and the high progesterone receptor positive, then they will be the candidates for the hormonal therapy, primary hormonal therapy. So That's all about the treatment of the endometrial carcinoma from the new guideline. Okay, with this, in my opinion, all of your part 2 and 3 questions will be answered, because I tried to put all important information here. This slide will be important more for part 2, less for part 3. But part 3 people also sometimes the role player ask the question, and these numbers that I have put here, this is from Cancer Research UK website. Okay, so 5 years survival stage 1, 2, 3, and 4 is this: 90, stage 1 90, stage 2 75, stage 3 50, stage 4 15. Okay, this is 5 year survival. That recently I got to know, now they are asking the 1 year survival. So overall 1 year survival will be 90%, overall 5 year survival will be 75%, and overall 10 year survival will be 70%. So this these questions are coming in part 2. So this so there are many sources from where you have to read the number, but I always read and speak about the Cancer Research UK. I find it authentic, though it will vary from there, here and there. So this is the answer to 5 year survival, and this is overall survival 1, 5, and 10 years. Now, the question started also coming about the uterine sarcoma. So these are the mesenchymal tumors, and this is sort of a classification. No need to remember this. I have put few things about the uterine sarcoma. So uterine sarcoma usually, like 4 to 9% of all invasive cancers. So leiomyosarcoma, it is like present in 48 to 54, and stromal sarcoma in like postmenopausal 41 to 63. No need to remember this. It usually they have the prognosis usually, we know the sarcoma have bad prognosis, but the prognosis related with the grade, adnexal involvement, and lymph node metastasis. Okay, apart from this, management of uterine sarcoma, this is from the BGCS. So total hysterectomy with bilateral selfingectomy, lymphadenectomy for staging is not indicated, and patient with low grade stromal sarcoma should not have post operative hormone replacement therapy. So this, you can get question from this line also. So they will say that the patient was for the surgery, and bilateral selfingo-oophorectomy has been done. Histopathology shows endometrial stromal sarcoma. What about the HRT? Your answer should come no. This question also I have seen somewhere. So if the patient has endometrial stromal sarcoma, for those that patient, HRT should not be given post-operatively. Even the routine use of anti-estrogen therapy is not recommended. So these two lines are important for your question point of view. If the advanced leiomyosarcomas are there, then they would require systemic treatment, when we as we use for all other soft tissue sarcomas. This will be gemcitabine and docetaxel, for advanced sarcomas. Okay, and advanced sarcoma can also be treated with anti-estrogen, progesterone, or aromatase inhibitor therapy. Because the questions about the uterine sarcomas are started coming. So this sort of this I have to say. So I will repeat it again: early disease, total hysterectomy with bilateral selfingectomy. HRT should not be given if the pathology is endometrial stromal sarcoma. Apart from this, advanced condition sarcomas, systemic therapy as other soft tissue sarcomas, it will be gemcitabine and docetaxel. Consideration for advanced, if the advanced disease is there, consideration for anti-estrogen, progesterone, or aromatase inhibitor can be done. This all update is from BGCS only. Now, this also you have to remember that leiomyosarcoma, usually question come from leiomyosarcoma, and 1% of uterine malignancy, one third of uterine sarcomas. This is important to know. Unfortunately, leiomyosarcomas are not diagnosed preoperatively because they are incidentally found when the patient is operative for leiomyoma. And there is a 0.12, the incidence is 0.1 to 0.3. This part is important to know. So you might have said that you if you guys would have known, there had been that was a case in the US, that one patient, she was operated for laparoscopy was done for for fibroid, and the fibroid mammectomy, laparoscopic mammectomy was done. And in the laparoscopic mammectomy, usually we morcellation is done. So the myoma removal in that case was done by morcellator. That caused spreading, and that was a leiomyosarcoma. And the patient died after that. For some time, that morcellator was Johnson had withdrawn morcellator for some time. It was withdrawn from the market. Now the morcellator has come back again, but now the new techniques has come. Now they are morcellating them within a bag, so abdominal spread is not there. So this you should remember. Because of that, this risk is significantly increased in the woman more than 50 years. Because of that, morcellation is no longer recommended in postmenopausal women and those who are whose age is more than 50. So I think the message is very clear here. So if the patient, because of the risk that it could be leiomyosarcoma, if the patient is more than 50 years of age, or if the patient is postmenopausal, usually the morcellation should not be done. And because point 0.1 to point 0.3 could be possibility of leiomyosarcoma. This number is from Strategy. Now the treatment we have already discussed. This is total abdominal hysterectomy with bilateral salpingo-oophorectomy. In young women, even the ovary conservation can be done. Lymphadenectomy should not be done because lymph node metastasis is very low. Adjuvant therapy is not beneficial, and like 70% will come uh, like with the distance metastasis only. Because of that, the prognosis is not good also. Palliative therapy will be gemcitabine, docetaxel, what I have already spoken, or doxorubicin. It is used in advanced disease, but mean survival rate is only 5 months. So it has a bad prognosis. Because of that, um, it is very important what they have put here, that there should be no morcellation. Otherwise, there will be upstaging of if the leiomyosarcoma is there. That's all I had to say. And now there would be some of the question for the exercise. Let's do that. So the patient, 51-year-old patient, uh, she has 2 month history of postmenopausal bleeding, and she was in a combined continuous hormone replacement therapy for 9 months. TVS shows normal size uterus. ET is 3 mm. Clinical examination fine. What will be the appropriate management? Anyone to answer? Anyone want to answer?
Yes, ma'am.
Yes.
Ma'am, inpatient hysteroscopy?
Yeah. Why in patient histoscopy? See, ET is 3 only, and she is on
But ma'am, you
already on the.
yeah,
Then
but
it
ma'am,
is
you said that even if that if it is postmenopausal and even and if there is bleeding, postmenopausal bleeding, now
but
she
it
has
is
2 month history.
recurrent bleeding only. Like we have to go for an inpatient hysteroscopy with less than
Yes.
3 mm
Yeah,
thickness.
Yes.
yeah,
So
yeah, but I thought because it is a 2 month history, so she is having repeatedly.
see, let me clear it. Here, what I spoke is recurrent postmenopausal bleeding. When the and the ET is less than 4, that time you have to consider doing hysteroscopy as per this BGCS guideline. So this is the clear message. Now, if you see this question, in this question, though it is less, but the patient has bleeding only one time, whatever. Apart from this, patient has got a risk factor. Patient is on CCT. So patient is on hormones. So before you investigate, what you will do?
Ma'am, the last option then?
Stop the
Yes.
hormones.
Yes,
Then.
investigative. Yes.
So first of all, you have to reduce, put all the hormones off. If the patient is still having problem, then only then only further investigation to be done. 65-year-old patient, BMI 40, early menarche, late menopause, type 2 diabetes mellitus, presented with postmenopausal bleeding. Cervical smear was fine. She had cervical stenosis because of that she cone biopsy and she developed cervical stenosis. Ultrasound ET is 20 Pipil biopsy in clinic and hysteroscopy anesthesia were unsuccessful. So, what you will do?
Ma'am, MRI.
MRI of the pelvis, ma'am, because it's already 20 and failed hysteroscopy.
Yes,
Uh,
ma'am.
so it's most apt for this.
MRI, then go for the
And many risk factors. She's early menarche, late menopause, type 2
diabetic.
diabetes, postmenopausal
Cardiovascular.
bleeding.
Mm.
Uh, yeah. Further step, ideally, it should be MRI. Would not help histology. Okay, what they say, if we the question is from strategy. Okay,
Yes, ma'am.
and the strategy says hysterectomy and bilateral salpingophractomy. Why not MRI? Because as we can't do biopsy, so we will not get histopathology. With the MRI, histopathology is not possible.
Yes.
Ideally, ideally, the in my this is from strategy question, so I have not changed anything. But in my opinion, uh, if they're asking further step, so first it should be MRI, then it should distract me.
Madam, this happening same. We have sometimes same confusion
Yes,
in that.
this happens, but we can't help it. This is
Yeah.
what the
Yeah.
I have not made any changes in the answer because it a strategy thing.
But the
Madam,
invasion,
such type of questions come in exam.
but the
Yes,
invasion of the myometrium is most appropriate with the MRI only, no, ma'am. But the histology cannot be seen. That is true. What you said.
But
yes.
as it is
MRI.
5 years of age, that's why they are going for the hysterectomy, I think so.
Yes, because see, if you have got no histopathology, to get they want to
Mm-hmm.
give you message that histopathology will not be there with MRI. Only my MRI will tell you myometrial invasion, yes or no. Apart from this, nothing will be told. Because of that, the answer is hysterectomy and bilateral salpingophractomy. But in my opinion, instead of writing question further step, it should be like what is a definitive treatment.
Yes, yes, ma'am.
Okay, but
Yes,
yes, but you should keep this also in the mind because this
yes,
kind of question do come in exam where you are
yes.
confused. Yes, but yeah, this is strategy question. So, 50-year-old woman with BMI 20, postmenopausal bleeding, come to your clinic. She's asymptomatic. Her examination is fine. ET is 6 Outpatient hysteroscopy is done, and cavities in last 8 centimeter, and adequate sample was taken. Endometrium was atrophic when they see on the hysteroscopy. They got the histopathology report. I think this question I have seen in the exam also, that some inactive endometrium, but the sample insufficient for diagnostic purpose. So what should be the answer?
Last answer, ma'am, because she is a low risk factor woman. Review the patient in a clinic in 6 months and repeat endometrial sampling.
But hysteroscopy has got atrophy. So atrophy, it will again the sample will not come.
See, ma'am, discharge the patient and re-refer
Yes.
them. Yes, ma'am. Okay, ma'am.
So this question I have seen in the exam. I think in
Yes,
my
ma'am.
exam, this
You
question
called
come,
it that.
had in the exam. Yes. Now the people will put, most of the students will put answer, last answer, but answer
Yes.
is C. Yes. So, and the message is also very clear. If the patient has atrophy at hysteroscopy, now you think clinically, if the hysteroscopy it is atrophic endometrium, so atrophic endometrium usually you will not get sampling because the ET is not there. So, uh, why to call patient after 6 months? Because again you will not find anything. So if now this patient has got some estrogen source in the body, then her ET will become more, then she will have bleeding. So best idea to call this patient when patient is symptomatic. Is it clear?
Yes, ma'am. Yes, ma'am. Perfect.
This is very important. Yeah, this is gives a clear answer. This way the exam question usually comes. So 66-year-old woman with GP with 2 weeks of bleeding. Her LMP was at a stage of 54. She had menopause. She had chronic hypertension. She has one child at 28, BMI 32, and she had a pupil biopsy. The result of later an ultrasound and MRI confirmed endometrial carcinoma confined to endometrium, less than half of myometrium. Okay, she is very devastated. What is the discuss of management? What should not be the first line? Now what is the stage of disease?
It's 1B, ma'am. Less than half of the myometrium invaded. 1A, A2, A2, sorry. 1A2.
Who? And what should not be the treatment option?
It should not be hormonal treatment, ma'am.
Primary hormonal treatment
Hormonal.
is done. I told that as I told you primary surgery, primary radiotherapy, primary hormone. So answer is chemotherapy, because primary chemotherapy is not done. If the patient cannot be operated, then the answer will be neoadjuvant chemotherapy followed by surgery, debulking surgery. So only primary chemotherapy is not done in endometrial cancer.
Okay. Okay.
Okay, so the 60-year-old postmenopausal woman using tamoxifen with a history of postmenopausal bleeding, TVS shows 6 mm. What you should do?
Outpatient hysteroscopy with targeted endometrial because she's symptomatic with tamoxifen.
Yes,
Postmenopausal.
very good.
Yes, ma'am.
Because as I already told that there would be tamoxifen causes stromal hypertrophy subepithelial, so ET will not be corresponding to its symptom. So best idea to look inside. So no, outpatient hysteroscopy with targeted endometrial biopsy. Now, this is easy questions. 38-year-old woman with intermenstrual bleeding with an endometrial biopsy of simple hyperplasia. What could be associated with the diagnosis?
Anovulatory cycles, ma'am.
Yes.
And ovary cycles, yes, ma'am.
Yes. This is easy question. So these all questions, but from strategy. Okay. Now 62-year-old woman in the gynecology clinic with postmenopausal bleeding. Ultrasound shows thickened endometrium. Hysteroscopy shows grade 1 cancer. MRI shows stage 1A endometrial cancer. So, what is the answer? Treatment.
Laparoscopic hysterectomy and bilateral salpingo-oophorectomy, ma'am. E.
Yes, yes, E is the answer.
Yes, ma'am. This is E.
So, the ultrasound is done for postmenopausal bleeding. ET is 8. Hysteroscopy and people is done. What is the risk of endometrial cancer in the woman with a postmenopausal bleeding?
Madam, 10% C.
And C.
Yes. Commonly question come from this table. This table you have to remember kind. So in the postmenopausal bleeding, what are the causes? So these are the causes. And usually endometrial hyperplasia will be there in 5 to 10%, and the endometrial carcinoma will be there in 10%. Exogenous estrogen, that is a HRT, in 15 to 25%. And sometimes they ask the most common reason, so answer will be atrophic endometritis and vaginitis, that is 60 to 80%. So this table is very important for these questions. Many questions come from here. So now the patient, 45-year-old woman, pelvic examination, has a bulky uterus, no palpable masses. TVS shows thickened ET of 20. People biopsy shows endometrial hyperplasia without atypia. Answer. Easy question.
LNG, ma'am. D, ma'am. LNG. First line is LNG.
Range. Okay. Again, now 49-year-old woman with previous smears fine, pelvic examination, bulky uterus, no palpable masses, TVS 30, ET is 30, biopsy shows endometrial hyperplasia with tibia. What is the treatment?
E, ma'am. Uh, Total abdominal hysterectomy with bilateral salpingo-oophorectomy.
Yes. Why the answer is hysterectomy, not the marina? Because they want best plan.
Yes, ma'am. Yes.
Though if they added the word best here, so answer is changed. Though the
Yes,
previous
ma'am.
question we have answer as Marina, and though it is an old question, but now it will be TLH and BS laparoscopy.
Madam, always with tibia, how can we put Marina with
Yes,
ATPia? Can put
atypia.
if we
Okay,
need
okay.
fertility sparing. Yes, ma'am.
Yeah.
Then
If the fertility is required, then Marina can be tried. But the,
but
first line or best for the atypia will be surgical only.
yes, ma'am. But you have said if they found the
Yes,
first,
yes,
yeah, why
yes. You
not
are
go
very
for
right.
the okay, okay.
Yeah. So it will be ideal answer will be TLH and BSO. Okay. Again, these are the staging questions. 60-year-old woman with postmenopausal bleeding and people shows adenocarcinoma. MRI shows invasion less than 50, enlarged pelvic nodes, subsequently goes hysterectomy, salpingophorectomy, and sentinel lymph node biopsy, 2 weeks follow-up. Myometrial invasion less than 50% with pelvic node involvement. What is the staging?
B, ma'am. 1B. It is more than half, 50% myometrial invasion.
You have to pay attention to two, three things here. Pelvic
Pelvic.
lymph node.
Pelvic lymph node is positive.
So if
Three.
the pelvic lymph node is positive, from the
Mm.
Yes.
previous
Yes.
staging
B.
and new stage, answer is 3C1,
Yes.
Yes,
pelvic
ma'am.
lymph node. Okay. Hmm.
Yes, ma'am. Yes, ma'am.
Be very careful while answering staging question. Staging question will come in the exam. 44-year-old woman with heavy bleeding and hysteroscopy endometrial biopsy was done. Histology shows papillary serous carcinoma. CT was done as normal, and I have already told you in that if the non-endometrioid cancers are there, usually CT chest is done. Okay, you can see from here also. CT is normal. MRI shows large tumor infiltrating serosal surface of uterus involving pelvic lymph nodes. Subsequently, abdominal hysterectomy, bilateral salpingophorectomy is done. So, what could be the answer?
3B, ma'am. H.
3B is spread to vagina, parametrium, or
Param.
pelvic peritoneum. Nodes are always see
Three.
pelvic
One.
node
Madam,
Yes,
3C1,
ma'am.
three C
Three.
one,
One.
three
Hmm.
C.
3C1, and para-aortic lymph nodes below renal vein, it is 3C2. Now answer is 3C1, both in old staging and new staging. And though you can understand here, it is papillary serous, so it is aggressive kind of cancer. But stage 3 and 4 staging is not changed with the whether it is aggressive and non-aggressive. Now, nowadays, whenever you see questions, you have to find out the stage and you have to look for the histopathology also. But in 3 and 4, it will make no difference. I just wanted to highlight that point because you can understand these questions are old only. Answer I am putting from the new guideline. So, this also you have to remember.
Yes, ma'am.
Okay, 82-year-old presents with uh, emergency department, postmenopausal bleeding. She receives 2 units of blood, undergoes hysteroscopy, endometrial biopsy, continue to bleed heavy, clear cell carcinoma. She had TLH, BSO, lymph node were done. Histology shows clear cell carcinoma involving uterine cervix and serosal surface. So, what will be the key point here that will decide the stage?
Involving uterine.
Se- Uterine cervix and serosa, ma'am.
There's a
Cervix is 2,
clear cell also. Yeah.
serosa is 3.
Hmm.
Sarosa is 3. Okay.
Yes,
So
ma'am.
so now you can see uterine serosa. It is 3A, but as in the new staging, A1, A2 has come. So ov- ovarian and fallopian tube spread is A1, serosa is A2, 3A2. So old previous guideline answer, previous classification answer will be 3A, but if your exam comes from new guideline, new answer will be 3A2. So this is the change from the new, if you do answer from new FIGO. Okay, this is the
Yes,
new
ma'am.
FIGO change. It is the clue here is uterine serosa involved, though it is clear cell carcinoma, that is aggressive cancer. But we know that stage 3 and 4, whether it is aggressive and non-aggressive, that will not change any diagnosis. Okay, 55-year-old woman with rapid access clinic with postmenopausal bleeding. She returns to clinic for people biopsy, which reveals endometrial cancer. She goes TH, BSO. Histology says infiltration less than 15% of myometrium, involvement of cervical stroma, peritoneal washings were positive. So, what is the disease stage?
It is stage 2, ma'am. A cervical stroma involvement is there.
Yes. So old answer is to stage A, 2, and new guideline, new answer is cervical stroma non-aggressive type A. So old FIGO, old classification, sorry, old staging answer would be stage 2, but new classification, new staging, as A has divided into A,
Hmm.
B, and C. So A is stroma, B is LSVI,
Hmm.
LVSI, and 3 C is always aggressive. C is
Yes, ma'am.
always aggressive. Okay. So I
Yes.
try to put small questions and comparison to make the things, a little easy. So 58-year woman in rapid access clinic with postmenopausal bleeding. She has outpatient hysteroscopy, endometrial biopsy. She has endometrioid carcinoma. She goes THBSO. Histology revealed endometrial carcinoma and involving endometrium. Peritoneal washings were positive.
1A1, ma'am. All it is only an endometrial adenocarcinoma involving the endometrium, na, ma'am. But the
Hmm.
positive for the malignant cells, peritoneal washings.
But peritoneal washings we are not using in the staging.
Yes, ma'am. So 1A1. Yes, ma'am.
So answer should be 1A1. Uh, Old answer will be 1A and new answer will be 1A1. And
Yes,
it
ma'am.
is
It's around.
not
It is around the
because it,
stage one.
yeah, yeah.
I like. I am saying that it is around the stage 1A, but I think so. Question will come from the new stage.
Yes, old stage 1A, new stage 1A1. You can see 1A1. Endometrial polyp or confined to endometrium. So here, though it is old answer, but they have not given less than 50% or more. They just say involving endometrium. So now answer becomes A1. And endometrioid, that means non-aggressive. If I change here clear cell, answer will become 1C. Answer will change to 1C. So whenever you put your answer from stage A, sorry, stage 1 and stage 2, please look at the histopathology to find out aggressive and non-aggressive, because your staging will change with it. Okay, now a few questions. So 40-year-old with postmenopausal bleeding, ET is 5.1. She gives positive history of cancer, endometrial cancer. Her brother has bowel cancer. Sister died of ovarian cancer. He's anxious for the genetic history, worried about some genetic condition. So what could be the cancer? It is easy question.
E, ma'am. D, ma'am. Endometrial cancer.
Yes, because they are speaking about Lynch syndrome.
Lynch syndrome.
Bowel cancer happen in Lynch only.
Yes, ma'am. Yes, ma'am.
Okay, again staging question. So 62-year-old woman with postmenopausal bleeding, USG hysteroscopy shows grade 1 endometrial cancer. MRI shows cervical involvement. She goes THBSO, that reveals grade 1 endometrioid carcinoma, less than half invasion with cervical stroma. Very clear answer here. Actually, I made the answer easy.
It's stage 2, ma'am.
One only. Less than
Cervical stroma
Stage 2, ma'am, it is.
two area.
And less
so
than.
and less than half myometrial invasion. So that is fine. It is less, but cervical stroma,
Yes,
that
ma'am.
will change that. So cervical stroma is stage 2A.
Mm-hmm.
Okay, and
Yes, ma'am.
if I write LVSI, then it will become 2B, and if I put clear cell, then it will become 2C.
Yes, ma'am. Yes, ma'am.
Okay, if I remove cervical stroma here and I write clear cell, then any aggressive, it will become C only. So answer will become 2C. Okay, so what is not true about the endometrial cancer except?
Yeah, ma'am. 80% of endometrial cancers are type 1 because all other are correct only. D. Okay.
Yes, type 1 are 80% which are in.
Mm-hmm.
Okay, so type 1 occur in early or perimenopausal or early postmenopausal. Okay, so this is
Yes.
this table is also important because you get question from this table also. Okay,
Type 1 are pole mute
endometrioid.
mutations and type 2 are P53 mutations, right, ma'am?
Usually like that only.
Mm-hmm.
But
Yes.
this is like old classification.
Yes, ma'am.
Okay, so 38-year-old woman went simple hysterectomy with ovarian conservations for severe menorrhagia. Histopathology shows well differentiated endometrial carcinoma limited to endometrium. What should be the next appropriate step?
A, ma'am. Simple lap hysterectomy and bilateral salpingo-oophorectomy.
Hysterectomy has already been done.
Then no adjuvant treatment.
Yes,
Yes,
no
no
adjuvant.
need of any treatment. 38.
So no adjuvant treatment is required for low grade cancer, and this is the low grade. Okay, 50-year-old woman with irregular bleeding. She had abdominal distension, pelvic ultrasound shows enlarged uterus with 14 ET, 10 centimeter bilateral complex masses. Pipple shows well differentiated carcinoma. MRI shows 3/4 myometrial invasion. What is the most appropriate action? What is the stage? What is the stage? Then the answer will come.
It is stage 2, ma'am.
2.
2.
2A. And adenocarcinoma and, well, 3
How?
quarters.
Yeah, the ovary.
Yeah, at complex adnexal mass. Yes. Mm.
So it becomes 3A,
3,
1.
3A. 3A, ma'am, it is. Ovary and fallopian tubes.
Oh,
Yes.
yes. Ovary. Yes. 3 adnex.
So what will be the answer? Stage 3. What is the answer?
Optimal
I,
debulking
yes.
surgery, ma'am.
Stage 3 and 4, optimal debulking. Okay, so 37-year-old woman with irregular bleeding 2 months. Previously treated for breast cancer, tamoxifen took for 14 years. USG histoscopy are fine. Histopathology shows atypical hyperplasia. What could be the treatment?
LNG here, ma'am. 37 years. LNG can be the first line without atypia.
Yes. So here LNG is not there, so progesterone will be the answer.
Okay.
Okay, that's all about it, people. So thanks for joining.
Thank you so much,
Anyone,
ma'am. It was very nice session.
anyone
Thank
of
you
you
so much,
have
madam.
okay.
Thank you, madam.
Anyone of you have any question can ask. Otherwise, bye.
Okay,
Bye,
ma'am.
ma'am.
Thank you. Bye. Thank you, madam.
Thank you, ma'am.